So hello, everybody. Welcome to the fourth event of our Translation Neuroimaging Educational Program. In this program, we coordinate a series of talks, discussions, and workshops with the hope to actively engage in the neuroimaging community. This educational program is nested within the Lifespan Working Group of the Enigma Consortium. It is a very inclusive program that welcomes everybody at all levels of neuroimaging skills and from diverse training background. The director of this program, Dr. Shalala has, and myself, and we do have an international advisory committee. Please consider to join our mail list if you want to be notified when we have new updates. We do have several social media channels. Please consider to follow us. And we have a YouTube channel, and there we have video recordings from our previous events. So if you have missed our past events, you can easily catch them up there. We also have a Twitter account. Well, now it's called X. If you are out there, please consider to follow us, and we will have updates about this program. Before I pass the microphone to our speaker today, I would like to briefly mention that our team is in the process of planning a series of events about neuroimaging-based brain age predictive models. The specific time is not determined yet, but we promise it would happen very soon. So please follow our social media. We will announce the time once it's confirmed. At the same time, if you wish to share your work through this platform, please get in touch with us. We will be very delighted to host you as a guest speaker. Today, I'm very pleased to have Dr. Chao-Gan Yan joining us today. Dr. Yan is a shining star in the neuroimaging community. He's a professor in the Institute of Psychology of Chinese Academy of Sciences, and he's the director of the International Big Data Center for Depression Research, the director of the MRI Research Center, and the PI of the RFMRI Lab. His research primarily focused on the resting data from my computational methodology, mechanisms of spontaneous brain activity, and their application in depression. He has developed a data processing and analysis toolbox for resting data from I, including the PARB and the parts everybody is familiar with this toolbox. And each of these toolbox has been cited over 3,000 times. He has published over 50 peer-reviewed articles in journals including PNS, molecular psychiatry, human brain mapping, and neuroimage. And his work has been highly cited in the community with a total number of over 20,000 citations. And currently he's in the editorial board of Imaging Neuroscience and Journal of Neuroscience Methods. And he's also an active member within the OHBM Communications Committee. Today, Dr. Yan will present their fantastic work on the establishment of the Depression Imaging REsearch ConsorTium, DIRECT. The DIRECT initiative is a fascinating resource for neuroimaging data from individuals with major depression. So he will present outcomes from the DIRECT phase 2 studies and will highlight the roles of the subgenual anterior cingulate cortex and also the dorsal lateral prefrontal cortex for the TMS treatment of depression. And Dr. Yan will also introduce their plans and share their insights for the multi-site clinical trials in the DIRECT phase 3 studies. So after the presentation, we will have a few minutes for the questions, and you can either type your questions in the chat box or use your microphone. But during the talk, please mute your microphone. So everybody, please join me to welcome Dr. Yan. Dr. Yan, now the time is yours.
Okay, so let me share my screen.
Yeah.
Okay, so could you see my screen?
Yes.
Okay, so it's my pleasure to have a talk at the program, and I think that you have several wonderful previous talks already. So I hope for this translational neuroimaging education program will be a great success in the future. And today my talk will be mostly related to the work we are doing, the DIRECT consortium and our previous REST-meta-MDD project. But most importantly, I want to talk about, because our vision is going to provide neuroimaging guided precision treatment for major depressive disorder. So most importantly, recently we have some projects on making such as TMIs procedure for treatment-resistant depression patients. And we have some very good outcome from this kind of trial. So I would like to share you, this is probably the most major point of today's talk. But I will still cover from what we are doing at the direct. And previously on our phase 1, we have some output. And phase 2, we have lots of research progress. And the phase 2 is leading to the phase 3. We have lots of research plans. And if you're interested in major depressive disorder neuroimaging studies, you are welcome to join us. So I don't want to repeat how important the issue of major depressive disorder it is, because it's over 300 million patients worldwide. And in China, is also very prevalent. The rate is 3.4% and have potential suicide risk. And many of us have recently heard some people killed themselves, potentially because of the academia system, but according to the relatives, probably said that is a depressive disorder. So given this kind of situation, how to best diagnose and how to best to treat them is our goal. So in treatment, that before treatment, we need to have some precision diagnosis. But in diagnosis that, the current diagnosis criteria for MDD are mainly based on symptoms. So using DSM-5 or using ICD-11. But there's no object biomarker yet. So at the beginning, our direct consortium is we would like to find out something that maybe we can use as biomarkers. And lots of scientists are working on that for using pro-inflammatory cytokine, HPA axis cortisol. But for me, as an imager, we are doing neuroimaging studies. So we want to use a functional MRI or structural MRI because this can reveal brain structure and brain function. And we may use those to examine what's the brain change in MDD. Although very recently, we started some initial collaborations using the inflammatory. We draw the blood from the patients and we do lots of metabolism. We do the immune system test of MDD patients, but it's a very recent work. Most of the previous done is we did on the neuroimaging, but neuroimaging find a biomarker because there's lots of issues. For example, small sample size, flexibility in data analysis, and the statistical issues. There's no suitable biomarker yet. And we have done a lot of work on that because sample size matters a lot. And you may aware the Nature paper that reproducible brain-wide association study requires thousands of individuals. And for us, we think if you want to build something neuroimaging biomarker for MDD, at least need thousands of individuals or tens of thousands. And how to do that, there's lots of neuroimaging database like HCP, ABCD, UK Biobank, and what Ruiyang has already mentioned, so Enigma MDD. But for us in China, we initiated a consortium called the REST-meta-MDD project. We call it Direct Depression Imaging REsearch ConsorTium. And this is based on our previous work building the DPAS, DPIPSurf, and which are widely cited. So we wrote emails to our users who conducted depression studies and asked them if they would like to join us for meta-analysis. You do not need to share your raw data. You only share your data using our software, standardized, pre-processed at your hospital, and you share with us. And what we have done is for the phase 1, because we want to build neuroimaging biomarkers for MDD, our goal is we want to use big data MDD, brain imaging, and deep learning. So in our lab, deep learning is still a strong line of research of our current studies. We have many students working on the deep learning part, but deep learning needs big data. If you don't have big data, then deep learning we are almost overfitting. So we also conduct neural underpinnings MDD studies. We have computation sharing platform, and we have lots of fMRI methodology work. We want to our method valid, robust, and solid. So we adjust head motion, standardization, multiple comparison, and all private work and all ongoing work. And I want to just spend a very few time to talk about what we have done in fMRI methodology. For example, head motion. So head motion will cause blurred imaging, like in structural imaging or in fMRI. And there's a lot of issues. Head motion can cause artifacts. How to best adjust them? So we have ESI top 0.1% highly cited paper propose all strategies to adjust head motion. And also we have strategies to adjust standardization. So how to better counterbalance the side effects. And we have a recent paper in Neuroimaging updated all suggestions. At Neuroimaging, if we want to have multiple data sets from multiple centers or hospitals, there should be huge artifacts caused by you have different machines, you have different coils, you have different scanning parameters. So we recommend the SMA a method to best to correct the side effects. And if you want to learn more, you can read our article in Neuroimaging. And also there's some issues about multiple comparison corrections. Back to 2016, there are lots of argues that in the field that the most widely used multiple comparison correction methods have lots of false positive rates, and we have lots of works on that line recommended what's the best way to address multiple comparison correction issue. You can also read our paper or use our sightings in our software. So when we develop the methods, if you do not have easy to use software, then nobody will use your methods. So we spend a lot of time to build a fMRI methodology toolbox. So lots of you are using SPM, FSL, AlphaNet, or FreeSurfer, but sometimes it's difficult to learn. So we developed the DPIB software, incorporated DPath, and we adapted all methodological updates like head motion, standardization, multiple comparison correction. And we have standard pre-processing pipeline, statistical toolbox, and have a platform for data sharing. So it's very widely used. It's a ESI top 0.01% highly cited paper. So if you are finding some software to analyze your fMRI data, probably DPIB is a good fit for you. You can learn of that. So based on this methodology work, so we wrote emails to the users who conducted depression imaging and asked them to share the pre-processed derivatives. So we constructed at the phase 1 have 1,300 depressed patients and 1,100 normal controls. So it's the largest MDD residency fMRI database, and we open sourced it. If you're interested in, you can apply the data. And the mechanism is the psychiatrists, the doctors, they do not need to share their raw data. They still have the control on our raw data. So we will train their students to use DPIB to do standardized pre-processing. And after pre-processing, they will share the pre-processed results to us. So we have a big data, we can do analysis, and then we can share all over the world. So this is the AlphaMax project mechanism. And this is our phase 1, the REST-meta-MDD dataset. This is there's 25 sites, and this is sex distribution. The female suffer more from depression, age distribution, and severity. And for the first paper of REST-meta-MDD project, we just answered a very simple question that there's lots of paper arguing the default mode network function connectivity, whether it's increasing of whether it's decreasing in the depressed patients. And then we use this data answer because this is the unprecedented large REST-meta data set of MDD. So we answer the question is the depressed patients have reduced default mode network function connectivity, and this is most obvious in the recurrent patients. And we adjust along controversial issue in the field, and this published in PNS, and is already entered the ESI 0.1% highly cited. And follow-up is we found the functional connectivity of depression brain was decreased, and we can figure out what's the topological properties, what's the network efficiency, and we found a decreased global efficiency and local efficiency in the networks. But it's not just only us to publish papers, because this is consortium and the members contribute data. So we also invited the participating hospitals. How would you like to analyze the big data? And you can have your own publications. And for example, Dr. Liu Zuoning published a paper in Neuroimaging Critical answering the brain dynamic function of brain networks. And Dr. Li Tao answered the sub-bell types in depressive disorder. And Dr. Guo Wenbin answered inter-hemispheric connectivity. And Dr. Zhang Kelang answered the subtype of gastrointestinal symptoms of MDD. And there are many, many more studies. If you are interested, you can read this paper published by psychoradiology. So this is what were objective and what's our future directions. And you can read the box 1 for our future directions for direct research. And for the phase 1, we accelerate open science in brain imaging of depression. We openly shared the direct phase 1 REST-meta-MDD data set. So there's up to now, the numbers I haven't updated, but up to now, there's over 400 international groups applied to use the big data in their studies, and almost 300 studies mentioning or use the REST-meta-MDD data, including some paper in molecular psychology and the Nature Mental Health. And if you're interested, you can access afm.org/REST-meta-MDD to access this data. And you can see most are from China, but lots of groups from the US and from the Europe, and also lots of from the South America. So this is a widely used data set, very influential in the field now. If you're interested, you can just apply the data set, and you can contribute to brain imaging of depression research. So this is the POS, the direct phase 1 research output. And I would like to talk more about direct phase 2 research progress. The direct phase 2 almost finished, but we are still struggling with editors and reviewers to publish the phase 2 papers. And one difference from phase 2 to phase 1 is phase 1 is using DPAS, it's using volume-based analysis. But there are lots of argues that the traditional volume-based approach is only 35% as good as the best surface-based methods. And you can read the PNS paper that why the surface-based analysis using FreeSurfer to construct the surface of the brain will work better, but why there are so few studies using surface-based analysis methods. So the authors also mentioned some issues, probably like the relative lack of turnkey tools for running a surface-based analysis, or the learning curve for adopting surface-based analysis methods is very difficult to learn FreeSurfer. So if we want to ask the doctors to use surface-based analysis for our phase 2, we first should build software. If we train them directly use FreeSurfer, that will be a nightmare. So we developed DPIB-Surf. It's based on alpha prep, FreeSurfer, ANS, FSL, alpha Palm, December X, GNU parallel, MATLAB, Docker, and DPIB. You can read our science bulletin paper on the DPAP itself. But basically, you do not understand what the under the hook, the engines we are using, because very complex. For you, if you are familiar with the DPAS, then it's very easy for you to use DPAP itself to do surface-based analysis. So we train the participant members to use the DPIB self pipeline to process the depression imaging data. And then now for the direct phase 2, this is surface-based data sharing. Each hospital uses DPIB self perform the surface-based analysis. And we have 1,600 unipolar depression and 1,300 homeopathic controls. And in this data, we even have bipolar disorder and a schizophrenia data set. So this is a very enriched direct phase 2 data set. So this is for the distribution for there's 23 sites contributed to this data set. And we also have international collaboration with Enigma, because Enigma has the most Caucasian data set, and Direct has a Chinese data set. Is there any cultural difference? This is also interested in. And we are collaborating with Dr. Liane Schumer with Enigma MDD. Now we have 64 institutions worldwide. You can have the distribution here. And we found the thickness of number in MDD. You can find mostly of the surface that the depressed patients have reduced cortical thickness compared with the health controls, like in the medial frontal prefrontal cortex, posterior cingulate cortex, and motor cortex. And this subgenus ACC, the very classical area of MDD, but we also found some increased cortical thickness at the visual area. And when we divided into direct, in this data, we found more difference in the medial prefrontal cortex, dorsal medial prefrontal cortex. But in Enigma, we found more at a subgenus ACC. But this represents the different pathophysiology. We are still working on that. And this also mentioned here is we need to think about in the subgenus ACC, the function in Chinese depressed patients. So this is, we are still trying to publish this paper in phase 2. And also in phase 2, we also wondering another issue. This is also connected to our phase 3, because in China, only 0.5% of Chinese MDD patients were treated adequately. So very small percentage. We need to work really hard to let people suffer from MDD to have diagnosis and have treatment. And even those have adequate treatment, we will find that about 2/3 of depressed patients cannot achieve effective symptom relief for the first antidepressant treatment. And they need to switch to other medicine after 4 to 6 weeks if there's no partial response. And there's 30% of patients have treatment-resistant depression, because recently we are started to treating treatment-resistant depression. This is a very severe problem because they have tried so many different medications, but that's not effective. And TMS is an established FDA-approved safe and effective treatment, but the problem is the brain is large, so where to stimulate? So some traditional methods use a 5 centimeter method. We find M1 and we made the 5 centimeter appropriate, then we stimulate that. But my brain is relatively large, and somebody's brain is very small. 5 centimeter means totally different. So somebody using EEG cap to find F3, and some people like, let's scan the brain, so have an anatomic scan, or we do a PET. But lots of people are moving the direction of using functional fMRI, because we think each patient's brain are different. They have different function. So probably they have a different functional target. How can we find a personalized target of each depressed patients? So this is lots of consideration. And Dr. Michael Fox has initially proposed that there's lots of moving forward to individualization using sgACC, because if you use a 5 centimeter methods, it will be very different from patient to patient. Even if you use F3 beam, there's lots of variations. And if you're using anatomical targeting, you have 3 variations, but the personalizing is very rare. So Dr. Michael Fox in 2012 find using subgenuine ACC and then do the functional activity with the dorsolateral prefrontal cortex. He found the anti-correlation between sgACC and DLPFC. The target place has a correlation with the clinical improvement. So this moves us that probably we find the individualized target using sgACC, and but up to now that in the review, only 6 studies use individual resonance data. For mine, very few people are using. And also subgenuine ACC at this structure, there's also issues because subgenuine ACC here has lots of noise, the low SNR ratio. So this probably can be a problem. Although Michael Fox proposed a method using seed-map method, but how to best address using seed-map to find the individualized target is still an ongoing trend in the field. And there is recently great news and very inspiring that from Stanford, Dr. Nora Williams' group. So they invented a Stanford neuromodulation therapy, SNT, and then they found in the treatment-resistant depressed patients, in the sham, there is no improvement, but in the actual treatment group, there's a huge decrease in the depression symptoms in the SANT protocol. So this is a very great direction, because this also our lab is tracing after. And their method has 2 novel points to me, I think. So first is they have very intense or accelerated the stimulation. They use 5 days. Each day have 10 hours, stimulating 10 minutes, rest 15 minutes, stimulate 10 minutes, rest 15 minutes. Is a loss of burden from the patients and from the experimenter. So our lab are doing this as well. So this very manpower demanding and resource demanding protocol. And another way is they use subgenuine ACC to do a functional activity, and they use some subunits to find the best target. But the algorithm, they didn't open source for that, but probably for patent issue, but we can only use our best guess to implement it. And using this kind of method, they found a great effect that they said 90% of patients with treatment-resistant depression have a response. So that's very great. And in this kind of issue, the FDA has already given clearance for SNT. So this has a good hope for treatment-resistant depressed patients. So what we want to do, find individual TMS targets, we want it precise, stable, and we found, because we have a big data for depression, we found it's a big data based. So what we are doing is, because we are direct consortium, the direction phase 2, we have 1,600 MDDs and 1,300 healthy controls. So we can use a approach that we use MR images. So we process with depressive. We do have the whole brain image with the sgACC, and we can use it to remove the set differences and use from the group difference mask. Group difference, then using group difference maps to get dual regression to find individual TMS target. This is all protocol or our way trying to best address the issue. And this is lots of previous papers using sgACC to find the DLPFC abnormality, and we use BA25 and the sphere to define the sgACC, and this previous Fox paper talking about the DLPFC sgACC correlation. And in our paper, we do find a group difference. And as Dr. Michael Fox Price did, they use a global regression. So we did find a group difference in the DLPFC with the subgeneric ACC. If you don't do global singular regression, we saw the loss of function decrease with the sgACC. But as a convention is a Michael Fox use GSR, so we are focused with the GSR pipeline, and we found the DLPFC has decreased sgACC connectivity in depressed patients. So our way is using this difference to get a TMS target. But first, let's figure out if the group difference has any clinical relevance. And we do find the DLPFC subgeneric ACC connectivity is decreased and is increased. The strength is decreased, but because of negative correlation, so the value seems increase as the compared with healthy controls. That's the DLPFC and sgACC, the competence or the anti-correlation is lesser than normal controls. And we do find this kind of t-value, the abnormal value, is related to clinical improvement. So getting this, we're trying to figure out some ways. We're using sgACC seed, we have group difference. We're using group to get dual regression to find the individualized target. Although we can use the mean MDD FC map to do that, or mean HC map to do that. And the dual regression is you can figure out search online, use the dual regression to figure out the way to find the individual target. And what we found is if we use a group target, then in a data set that we find no clinical improvement correlation with the target offsite. But if you use an individual target, the offsite targeting will have a clinical improvement correlation. That is, if we calculate the individual target, if the actual TMS target is closer with the individual target, it had a better clinical improvement. It is far away from the target self-set, then it have a worse clinical improvement. So this is a way we think our method can work. So this is in our phase 3, we train to recruit treatment-resistant depressed patients to prove this way. And this is if using MDD patients mean correlation. It has an effect, but not as strong as your group difference. This is you have the controls. And then we also implemented the SAND protocol. And we found the SAND protocol is 0.36, but using all individualizing target. So the group difference map, we have the strongest anti-correlation. So that means seems all big data-based individualization will have a greatest treatment effect. This comes from retrospective data. So we want to use prospectional data to prove that. So we called in the direct consortium for phase 3, we asked the hospital to join us that we calculate the TMS target. And we ask the hospitals to do double-blind randomization, seed-burst treatment, and we have the TMS robot to do that. That is, we calculate the individual target and we import it to the computer. The computer will move the robotic arm to actually stimulate the precise target. So here I would like to share you with some of the direct phase 3 research plan. phase 3 research plan, first direct individualized precise TMS study. And this is we want to enroll the different hospitals to our protocol. But first, we need to demo this works in all center. So here is our robotic arm, and here is the camera, and it looks like that. And here are the patients, and we have the interview of the patients. They needed to meet the treatment-resistant depressive definition that at least they have 2 adequate medication treatment, and those 2 different medicines doesn't work for them, and they are suffering from the depression. And this is the patients. We have the talks before the treatment and after treatment. And actually, the effects is as good as I can view the effect with my eyes. At the first day, they are very depressed, and at the 5th day after treatment, they have a very good relief. And this is our initial data that the big data gathered individualized TMS targeted process intervention for depression. So this is our patients, the cameras, and robotic arm. And now we have 9 patients, treatment-resistant depressive patients, finished our protocol. So you can see in the 5 days, we have the HAMD-6 scores. And during the 5 days, those HAMD scores dropped dramatically. So that means our TMS therapy works for them. And if we look at the baseline and the final for HAMD for the 9 subjects, they have a dramatic decrease in depression and a dramatic decrease in hormone, the anxiety. But you will see that one subject, the decrease is relatively small. We are still figuring out why the method most works for most of patients, but some not work as well. So this is a issue we need to do research in the future. And you will see that for the 5 days, the big data guided individual TMS treatment is good. And you may argue that how the effects last. Can the effects last long as several weeks after? And we do have that data. And this is but we follow up by weeks and months. And you will see from the HAMD, you will see most of the patients can have very long-lasting effects. So this is pretty good that after 5 days treatment, you can see dramatic change. And after weeks or months of follow-up, they still can remain the effects. So this is pretty good, and we wanted to further explore. And the anxieties, you see their anxiety is changed. And this is why we want to invest more source to this project that seems we figure out a way to help the treatment-resistant depressed patients, and actually we are changing their lives. Now also in the direct phase 3, not just only a TMS study, we want to examine the brain maximum or antidepressants. So at the beginning of direct consortium, we want to figure out some imaging biomarker, but we still cannot figure out that. But in our philosophy now is we want to figure out some treatment effect. If we figure out what works for the brain to address the depression problem, maybe that's a better biomarker to get treatment. So in the PNS paper, we found the medication has an effect in functional activity. And we, Dr. Sutiame, we found the treatment, 8-week treatment reduced the brain functional connectivity. And we have a Mendel Flower project here to live a joyful life that in the first phase, Mendel Flower, we have econ psychotherapy. We have about 50 to 60 psychotherapists now, and they can do the standard econ therapy. And we also phase 2 have a subclinical depression intervention. We're using the music therapy, and we're using mindfulness living group intervention, and we have the TMRs. And we also collaboration with the psychiatrists in the hospital. We have the direct mechanism. And for the phase 1, the Mayflower project, we found this is a regular depressed patient. They are not treatment resistant, but they are regular depressed patients. We find that the psychotherapy can reduce HMD depression or their self-rating BDI depression and HAMA anxiety, and also improve their insomnia and improve their self-rated the self-efficacy. And those are self-reported, but we do have the cognitive tasks like emotional and back tasks. And this kind of therapy can improve the accuracy and reduce the reaction time. And on the brain wet can reduce the brain functional connectivity like the medication. And for the music therapy and the mindfulness living group intervention, we do have our therapy can reduce HMD and HMA. And this is the project 3 is the TMS targeting, and you already heard in the previous slides. And in all whole project, we want to figure out if there's kind of treatment effects. So we have pre and post, no matter it's therapy or TMS or medication. And in the future, maybe we can figure out a way using brain network marker that for figure out some subtypes. So for first subtype, it may be you suitable for sex therapy, and some other types maybe suitable medication, or you need to go to SNI, you go to SNI, or if you are treatment resistant, to go to TMS. So that you can read the science bulletin paper here that we have a prototype that we scan their brains, we give different scores, and we tell them different subtypes suitable for different treatment. And want to build a network. We have scientists, we have sex therapists, we have psychiatrists, and we have social workers to help those jump in depression to better go back to normal functioning. And also we have function structure fiber coupling side because we build a DPAP fiber. Eventually in all software, we build a DPAP fiber very easy to FA, ADC, TPSS, or home brain fiber instruction, or do the automated fiber quantification, or do the DPAP fiber structural functional coupling. So we plan to train the direct consortium how to use DPAP fiber and to accumulate the big data of DPAP fiber DTI data to using the same mechanism to research their brain structural function coupling. And also we have our own tasks like illumination, stimulation source. And I do not have too much time now to explain for you so our illumination line of study, but we do have lots of illumination. We have the cognitive paradigm, we have fMRI, and we have some hypotheses why the brain have the core and the DLPFC have a reduced functionality, dropping in depressive rumination, and we should have TMS to target for rumination. And also we have some other lines using synchronous paradigm to figure out what they are thinking about, and thinking about the content and the brain activity. And we also do some research why the depressed patients have different thinking style as normal controls. And finally is a consortium for rational norm reference. So we spent so much time that we still didn't find out imaging biomarker for depression, but there's some hope that in a Nature paper that if you have a human brain norm, you use the percentile score compared with a norm can significantly enhance the diagnostic efficacy of the disease. So I understand that Dr. Ruiyang is spending a lot of effort on this way using brain centile. So this is if using the Nature paper, they only have 4 Chinese research teams participated, cannot represent the Chinese population, and only 4 brain structure indicate no function data. And we think schizophrenia or major depressive disorder, those psychiatric disorders may have a brain function abnormality at the beginning. So we want to have the data for brain structure and function norm. And our previous study has shown using norm can improve the reliability. And we want to build a Chinese resting state function among non-reference. We call it resting consortium. And this can move in towards individual abnormality detection, brain disease, and all target sample size is more than 200,000 people. So we started mobilizing the images in China to do data aggregations and pre-processing, non-construction, and do disease application using the same mechanism as our direct consortium. We consult together, build together, and share together. And then once we have a brain structure and a function norm, we have the curve. And if you're at the age 60, you can examine your hippocampus volume if you are following the lowest 5% in the population. You may need to think about something related to Alzheimer. And then we have initiative meeting, and then we have academic committee of resting consortium, and then we have a literature search over the Chinese resting state from our papers. We have more than 200,000 participants. So we are doing that, and we have a resting state consortium WeChat group, and you can add my robot to add in this kind of consortium. So this is our hope that we can spend more time in the direct phase 3, and we can achieve that we're using brain image to better diagnose and treat depression patients. And if you want to learn more of our study, you can learn the CCTV documentary or BRTV documentary, and you can scan the QR code from our lab. And I would like to thank my students, collaborators, funding resources, and then thank you very much for your attention. Ruiyang?
Yeah, that's very brilliant and very impressive talk. And first of all, I would like to thank Dr. Yan for the talk. And for everybody, I would highly recommend everybody to use the DPABI and DPABI Serve. When I was a PhD student, I used the DPABI a lot. And I can tell you it's one of the most useful and user-friendly toolboxes I have ever used. Now I'm very eager to input my data to the DPABI Serve because I have no experience with that new toolbox yet. And so everybody, if you have any questions, please type your question in the chat box, or you can use your microphone directly to raise the question. And
yeah, for those watching the live streaming, you can also type your question there.
Yeah.
But live streaming, they said 620 watched. And
yeah. So I have a question here. So it's from our student, Jordan. Thank you, Dr. Yan. I was wondering, how do I apply to use the direct data? Thank you. And are there any constraints when using this data? The shared data, metadata, or the raw nifty images?
So let me input the link to you that you can learn from you can apply from the link that how to use the data. And the data is not raw data because we didn't ask the hospital to provide raw data because the mechanism you do not need to provide raw data. You use all software standard processing and share the final results.
Okay. Yeah. So, okay. So I do have a question that puzzled me a lot about the sgACC DLPFC functional connective, because I do have a little bit of experience with that. I found that as you show in your slides, that only when you did regress out the global signal, you can find that link between the two regions. I mean, the sgACC and DLPFC. If you do not use that global signal regression procedure, it's not easy to find that link. I mean, this is a very controversial topic in the field, and a lot of people argue that you cannot move out the effect of a global signal because the global signal is biologically meaningful. I just want to hear your thoughts about this issue. Should we do that or not? Or if it works, why not?
Yeah, actually, I talked with Michael Fox about this issue. That actually, it's like if you don't do global singulation,
Mm-hmm.
cannot figure out the anti-correlation because you
Yeah.
cannot figure out anti-correlation because the global singulation effect is so strong. So if you don't do global singulation, you cannot find the anti-correlation.
Yeah.
And in the theory, like Michael Fox, it should be an anti-correlation, meaningful that the subgeneral ACC and DLPFC, they have competition, and you only can do global singulation to figure out the competition. If you don't do that, you cannot figure out the competition. So I agree with that. And finally, McFox agreed, and I also agree that doesn't matter mathematically or mechanism or any mechanism, but it works for MDD patient. If you use this to figure out target and you can cure their depression, and you don't care what's the mathematics or the mechanism.
Yeah, true. Maybe that's the different sort of from a clinician's perspective and from a neuroscientist perspective. But yeah, I agree with you that if it works for the clinical population, why not? Yeah. And do we have more questions?
Very fun, raise her hands.
Yeah. And also, like, okay, no good. I have another question about the the in abnormality of the subgenual cingulate cortex, the functional connectivity of that region to the other part of the brain. Because a lot of study they found hyper functional connectivity of that region, right? But I remember your paper in PNS, you show that actually in the data in the direct data that you has the Chinese depression cohort, you found that actually it's hypo functional activity or sgACC. Do you have any
The
ideas
first
how
in our data is we found a reduced default mode network function is mostly in recurrent patients. It's not the first episode drug naive.
Yeah.
Actually, in first episode drug naive, we didn't find significant effects. But for the recurrent, there can be a treatment like a medication effect. So
yeah,
this is why we are very curious about the treatment effect.
yeah,
Up to now, for the the major function connectivity itself is very noisy, and it has very affected by global singulation. So this is we still have concern using functionality to build biomarkers or build anything. So our group has lots of study using new machine learning method like the time series learning to my student has figured some way to replace the current functional Pearson correlation methods, but soon maybe you will learn from our recent studies.
yeah. I very look forward to it. And I think it's probably like the different results from yours and others perhaps stem from the heterogeneity of the population.
Yeah, and still, I don't trust the functional activity, at least from the current point of my view. I don't trust Pearson correlation functional activity. We have so many papers. In depression, most of the thing I trust is medication will reduce functional activity. Because this I found again and again, we trust about that. But for otherwise, we still need to figure out a better methods. Better, robust, reliable, and generalizable method to do functional imaging research. I don't trust the current Pearson correlation. Because at individual level, it's too noisy.
Yeah, I agree. And just to remind everybody, in our third event of this program, we had a PhD student from Germany. He gave us a fantastic talk about different methods for functional connectivity instead of just the Pearson correlation. So if you want to have a look, please go to our YouTube channel. We have the video recordings for that talk, and maybe you can have some different perspective of functional connectivity, not just using the Pearson correlation. Yeah. Do we have more questions?
Jianjin, do you have any question?
So we have one more. Great talk, Prof. Yan. Do you have any plans to combine MEG or EEG for MDD?
Actually, I sent a student trying to collect fMRI simultaneous EEG, and finally he gave up this project that because it's too complicated to clean the EEG data from the MRI magnetic noise.
Mhm.
So then later we dropped that direction, but maybe in the future we can think about the separate, not the simultaneous EEG fMRI, but separate fMRI EEG. That should be doable in the future. This is something we can do. And especially with the MEG, with the better signal quality, that's our hope in the future.
Yeah. Yeah. That's great. Do we have one more question? Okay. Yeah, I think that's it for today. So thank you everybody for joining, and especially for Dr. Yan to have a wonderful and brilliant talk for everybody. And I think the direct, individualized, precise TMS study is very encouraging and very promising for clinical practice. And we really look forward to hear more from your group. And thank you very much.
Thank you.
Thank
Thank
you,
you very
everybody.
much for organizing.
Have a good day.
Bye-bye.
Bye.